So Dr. Lumsden is the chairman of cardiovascular surgery, and he's going to talk to us about percutaneous interventions for aortic aneurysm. What does the clinician need to know, and what does the surgeon want to know from the imager prior to and after the procedure?
Well, thank you. Congratulations, basically, on a great program, actually. So what I'm going to talk about is really, I'm a vascular surgeon, so what I really need to know from the aortic imagers to allow us to actually treat these patients. Now, these are my conflicts. Now, one of the most common questions that I always get after any presentation is, where on earth are you from? So this is a little bit of a clue, and so this is your first multiple choice question. Where am I from? A, Scotland, B, Scotland, C, Scotland, D, Scotland. And the answer, of course, is E, all of the above. So this is why you can be a little confused, basically, when you go to Scotland. I was going to give you these choices of which of the bathroom that you actually got into. We were the original, basically, in having unisex bathrooms. Nobody quite knows where to actually go to. So at the end of the day, we're really pretty simple plumbers. And that is, what do we need to know if we're going to put a stent graft in a patient? First thing we need to know is, when should we fix the aneurysm? Why is that important to an imager? It's really about diameter. Well, sometimes we see the aneurysm measures 5 centimeters long, 5 by 15, and 15 always gets their attention. We don't really care how long it is. The length of particularly an infrarenal aneurysm or a thoracic aorta is almost irrelevant. Now, one question I'd like to ask is, of the audience, how many people consider themselves primarily experts in echo versus the other modalities? So echo first. What about CT and MR? All right, what about interventions? I don't know who everybody else is that you got in here. That's good. Okay, so that helps me calibrate this a little bit. So the questions then are, when should the aneurysm be fixed? We're going to address that. How can it be fixed? What are the technical considerations for us in stent grafting? And then once we put a stent graft in, how are we going to basically follow those patients up? And we'll cut it off at that point in time, because I'm the guy who stands between you and coffee resuscitation, which is going on outside. So when should an aneurysm be fixed? And again, I'm really only going to include 2 categories. Ross has kind of talked a little bit about the ascending aorta. Let me focus on descending thoracic aorta and abdominal aorta. AAA, size, 5.5 centimeters, with some caveats. Descending thoracic aneurysm, 5.5 to 6 centimeters is tend to what we think about. Symptoms. Any patient who has a symptomatic aneurysm, we're going to fix it. Now, the problem is the overwhelming majority of patients are asymptomatic. You can't depend upon a patient going from asymptomatic to symptomatic, choose to fix them. That symptomatic period can be very short. And any patient who's got a significant sized aneurysm who develops symptoms, we're going to admit and we're going to fix them semi-emergently. And an abdominal aortic aneurysm lies in the front of the spine. Most patients do not present with abdominal pain. They present with back pain. So an aneurysm of 5 centimeters and greater with back pain, new back pain, different kind of back pain from the patient may have experienced a lot of their life, is something that we find very alarming. Likewise, a descending thoracic aneurysm, often back pain, left lower chest pain can be associated with it. So size drives the indications for intervention. Symptoms basically heavily drive our indication for intervention. And anytime we follow these patients and we see rapid expansion, that certainly gets our attention. Now again, there are certain ways of qualifying this. A small woman who has a 5 centimeter aneurysm has a statistically bigger and higher risk of rupture than a large guy who has a 5 centimeter aneurysm. So we take these things into consideration. The morphology of the aneurysm is something that we also consider. Most aneurysms are fusiform. And the fusiform you can see here, diffusely enlarged. A few are saccular. We generally think that the saccular aneurysm is a little bit more alarming, probably based upon mechanistic issues than are the fusiform aneurysms. So these are the kind of things we take into consideration in making a decision to go ahead and intervene on the patient. And lastly, some patients are completely incapacitated by this. Most patients, you got an aneurysm, Mr. Smith, we'll see you again in 12 months, no problem. Others, basically, every time they have a twinge, they're completely incapacitated by that. And we take that into consideration in making a decision to go ahead and intervene on these patients. So, the diameters, the things that we want to know from the technical standpoint, basically, are the proximal and distal landing zones. All of these stent grafts essentially act like a pressure fit. They're almost all nitinol, and the way basically we put them in is you put them inside and we oversize a stent graft. So if it's a 25 millimeter diameter aortic aneurysm, we're going to put in a 28 stent graft. And so the stent graft sits on the inside and pushes up against the wall of that. If you have a 28 internal diameter aorta and you put in a 25 millimeter stent graft, that's not a good day, because when you release it, the whole thing is going to drop down into the bottom of the aorta. So the very important things for us is, where is the stent graft going to fix inside the aorta? And by and large, those consist of two areas: top of the stent graft, the bottom of the stent graft, usually referred to as the landing zones of the stent graft. We need the diameters of those, and we need the lengths of those seal zones. And I'll show you some examples of that. Almost everywhere, we need at least approximately 2 centimeters of relatively normal aorta. And we can squeeze that occasionally. But if you get a nice diameter and at least 2 centimeters of relatively normal aorta, you should get a good result from stent grafts. Where we have seen failure starting to occur relatively early is where we push it on the limits of these seal zones proximally and distally. Second thing we need to know, just like TAVR, is how on earth are we going to get this thing in there? I mean, these catheters, by and large, are as big as my little finger, and trying to put a 6 or 7 millimeter diameter device inside a 4 millimeter calcified artery is fraught with hazard. So understanding what the diameter of the approach vessels actually are, how tortuous they happen to be, and how calcified they are is very important in understanding what that approach. We can go around them. We can put conduits. We can sew things onto iliac arteries to get us around that. And lastly, the quality of the aorta at these landing sites. We basically talk about endoleaks, how when a stent graft is placed and it infolds in the inside of the aorta, that you can actually get what is the equivalent of paravalvular leaks. We refer to these as type 1 endoleaks, and we'll talk a little basically about that. So the most important thing when I see a patient in the office, I'm looking at these seal zones. What does it look like proximally and distally? And really in the infrarenal aorta, it's really all about that proximal seal zone. We can kind of rig the bottom end of this, but what we're particularly interested in is from the renal arteries inferiorly. Almost all the original stent grafts were designed to be placed in the infrarenal aorta. This is the most common area that you get aneurysmal disease in the aorta. Almost never anymore do we see aortas that have this nice long 4 to 5 centimeter long of parallel aorta. But this is the ideal seal zone for putting one of these stent grafts. The initial stent grafts needed 2 centimeters. More recently, they went down to 15 millimeters, then down to 10 millimeters. It remains to be determined whether those are going to be durable. And what we're seeing now is that late follow-up of these stent grafts, this is a race between patient mortality and aortic failure. Over time, the aorta dilates, and often basically that can lead to problems down the line, which we'll touch on. So, proximal seal zone, distal seal zone in the iliac arteries, most commonly in the common iliac. It's difficult to be absolute because now we have branch grafts which go down into the internal iliac arteries. We can move the seal zone down peripherally. Every different manufacturer, as I'll show you, has a different way of measuring these and sizing for these endografts. Iliac internal diameter, iliac tortuosity is important to us. An inferior mesenteric artery patency, if you ever on a CAT scan in an aneurysm, you see big inferior mesenteric artery coming out of the abdominal aorta, next thing you look at is the origins of the superior mesenteric artery and the celiac artery. It may be big for a reason, and that reason may be SMA and celiac are stenotic, and that IMA via the meandering artery supplies the entire small intestine. Very bad day in the operating room when you take that out and the patient loses the entire intestine post-operatively. So we try to avoid those kind of things. You heard a little bit about the importance of measuring true cross-sectional diameters. A lot of this was developed out of the original aortic endograft world, and making sure that we looked at these in multiplanar images. We line up the center line of the aorta and we measure a true cross-sectional diameter. That's going to be extraordinarily important in trying to figure out how we're going to manage these patients. So every manufacturer, this happens to be from Gore, has their own what we call sizing sheets. We're not asking you to do this. This is what you need to do is to deliver us a high-quality CTA. A non-contrast CT scan is worthless, essentially, for sizing for an endograph. We need to know what the internal diameter is and the external diameter. Most manufacturers size endographs by lumen-to-lumen measurements, but not all. And so what we tend to get presented with is a sizing sheet which shows us angulation of the neck, which we can measure, the length of the neck, the diameter of the neck, whether there's any taper in the neck. In other words, we measure a diameter immediately below the renal arteries and when the aneurysm starts, and if it's conical shape, then guess what happens over time? The stent graft displaces down into the aneurysm. And so greater than 2 millimeters taper, not good. Doesn't necessarily exclude us, but again, we'd weigh up what's the risk of open surgery versus the risk of putting an off-label graft in a situation like that. The length from the lowest renal artery to the bifurcation, also very important, because I'll show you most of these grafts basically have a short side limb that we actually come up the opposite side and dock an iliac limb into it. And then there's a series of measurements on the iliac artery where we're making a decision about whether we're going to use what would land in the common iliac artery or whether we need to come down into the external iliac artery. So again, this is just basically an example of what these measurements actually look like. This is measured in every patient in terms of sizing, what we're looking at. And again, each manufacturer, has different indications and exclusion criteria. The quality of the aortic neck is affected by two things. Number one, the amount of calcification, and number two, whether there is circumferential or partial thrombus lining on the inside of the neck. When we see that on a CTA, it increases the risk that we can embolize into the renal arteries when we deploy this. So again, in this manufacturer, they don't measure outer wall to outer wall, they measure inner wall to inner wall, and we measure basically all of these different components. And this is just an example of what this can look like. One of the reasons they measure inner walls because this is the same diameter and we have exactly the same stent graft. For example, this would be a 31 or 33 millimeter stent graft, regardless basically of what is happening, in the outer part of the aortic wall. Then you take these measurements, you go into these sizing sheets, which tells you which stent grafts, which fit each different type of anatomy. And typically most stent grafts look something like this. I mean, how do you get a bifurcated graft? And you put them in as two components. Is what we call the main body. This would sit below the renal arteries. An ipsilateral limb, which goes down the iliac artery, and a little short leg, which dangles inside the aneurysm. And you kind of come up the opposite iliac artery, you fish out that hole, you put a wire up through that hole, and then you put an iliac extender limb. And so this is kind of like an erector set for adult. You got all these different components. You try to do this with the minimum number of components because component separation is another issue, which actually occurs in these patients. So the clinical scenarios around aortic imaging, basically the diagnosis up front basically can be done by ultrasound or CT scan. Often patients get a KUB and they see the calcified wall of the aorta. That leads them to get an ultrasound or CT scan. In a patient who's an aneurysm down a 3.5 to 4 centimeter range, we usually just follow them with ultrasound. However, it is important. Aneurysmal aortic disease, the analogy I use, if you were a colorectal surgeon and had a patient referred who had a sigmoid colon cancer and you took out the sigmoid colon and you ignored the rest of the colon, that's considered malpractice. For many years, that was not the case in the aortic disease. The aorta needs to be thought of as an organ, and at some point, the entire aorta needs to be evaluated in this patient. And one of the reasons this was a problem because it kind of was segmented into the vascular surgeon owned from the middle descending thoracic aorta distally, the cardiac surgeon looked up above, and nobody actually looked at the entire thing. And the highest risk factor for having a thoracic aneurysm is having an abdominal one and vice versa. You got to see the whole thing. The only way you're going to do that really is with CT or MR at some point. You don't need to do that every year. So diagnosis can be done with ultrasound, CT, less commonly MR, yearly follow-up. If it's basically you're not planning to do an intervention, it's in the abdomen. We use ultrasound if it's in the chest. Basically, we use a CT scan. If we're going to intervene on these patients, almost all of them have a contrast-enhanced CT scan. Exceptions to that could be with an MR, in a patient with elevated creatinine. We use FollowUp. FollowUp will give us fantastic MR. We can fuse MR in the operating room. We can actually work. We can plan the procedure and we can work off an MR. When we do the procedure, we're all doing this basically in a hybrid room now, and the hybrid rooms really allow us to bring all of this imaging technology, into the operating room. It used to be that we had a portable angio suite, or in the form of a C-arm, Now these hybrid rooms are amongst the most sophisticated imaging suites that actually exist, and we use all of this in terms of managing these patients. And I'm not really going into the new paradigms in terms of imaging these patients. So essentially, this is a little bit about how we evaluate them. One of the real concerns, if we see circumferential calcification of an iliac artery, that's a recipe for disaster. There are ways of trying to handle that. But if you see something like that, you're better off just making a little incision, sewing a graft on here, and bypassing around it. Neck angulation is important to us. In the CT scan, we look at it, we actually choose what we call the gantry angle. Because the neck of the aorta often drops posteriorly over the curve of the lumbar spine, you have to angle the image intensifier at the time of implantation in that direction, so we truly see where the renal arteries are. You're trying to put these stent grafts right on top of the renal arteries, or as close to it as you can get. This is an example of what you get. Posterior angulation. If we just go AP with the imaging, we will actually miss the renal arteries, potentially cover them. You need to angle it to take into account the angulation of what you get here. And this is something you almost never see, and this is a typical example of great angulation. Going from that CAT scan, a long neck, this is the perfect anatomy. This patient is going to do very well with an endograft. When that neck becomes short, and whether there's dilated common iliac arteries and the seal zones are compromised, that's where some of these long-term problems, have really been found. And I'm going to go on through this just a little bit and see if I can catch us up on it. So how do we follow up stent grafts? When you fix a stent graft, whether it's in the thoracic position or the abdominal position, it is not fix it and forget it, okay? When you do an open procedure, fix it. These patients are going to do well for years and years and years after we get them through the initial operation. Nearly 15% of people who have stent grafts will require a second intervention sometime in the next 18 months for a remedial intervention. It may be something as simple as stretching up one of these iliac limbs to seal it, or it may be much more complex than that. The other thing the patients need to be followed up long-term for is the change in aneurysm conformation. Patients love it when you come in and you say, hey, they always want to know how big their aneurysm is. It used to be 5.5 centimeters, now it's 4.5 centimeters. They think that's great. That gives us a sense of anxiety. Because when an aneurysm shrinks, it shrinks both in diameter and it shrinks in length. And that stent graft is fixed, top and bottom. And as it shrinks, it bends that stent graft. And as I said to you, there are little pieces that we put together, and those little pieces can come apart. And that seal zone that we've created can lose seal. That tends to occur in a longer term as the aorta dilates. Now, I've been in Houston now for 11, 12 years. I think as a vascular surgeon, you should probably move every 7 to 8 years. Then you think you have no complications, and the reality is that you do really well. So the guys at Emory are picking up all my problems. And so, again, there was recently a conference called Critical Issues America. It was all about long-term issues with this. And now when you start getting to 10 years, you're going to start seeing these aneurysms getting bigger again. And we got to figure out what the remedial interventions are. So choosing the age of the patient is important. So they need to be followed up long-term. They don't need CAT scans every year. If it's stable, we often alternate, at least in the abdomen, with an ultrasound scan. A little more challenging if you're up in the chest. The main failure modes are a little bit different, and it's the big issue is endoleaks. Now, how in our wisdom we ever used the word leak in relation to an aortic aneurysm, basically, and then gave a classification system for it is beyond me. That was a terrible mistake for what we did. And I'm going to go on through this and go on and just talk about endoleaks, because I spend half my life explaining to a patient that they have an endoleak, but not the kind of leak from the aorta that actually kills them, because you use the word leak from an aneurysm, it freaks the patients out. So you put the stent graft in, again, just looking at an abdominal stent graft. Seal zone, seal zone, seal zone. These things can leak in a number of different ways. Again, not leaking aneurysm, leaking into the aneurysm sac. So when you follow these patients up, and either by ultrasound or by CT, you see dye by CT, or you see flow in the aneurysm sac. There are a number of different ways it can get there. It can get there because it loses the proximal seal zone. Blood flows straight down alongside the stent graft, straight into the aneurysm. Type 1B is when it comes retrograde along the iliac arteries. These are high-pressure endoleaks. This is aortic flow that is going straight into the aneurysm sac. This must be fixed. This patient basically is at high risk of rupture. Not that common. Type 4 endoleak basically is where there's graft, and I'm going to come back and spend some time in type 2. Type 4 basically and 5 basically are where essentially you get this weeping concept that occurs through. Some of the original grafts were not completely porous. Some of the PTFE grafts would ultrafiltrate fluid through the wall of the graft into the aneurysm sac. We couldn't figure out why they were getting bigger. It was filled with a serous looking fluid that was being filtered through the wall of the endograft into the aneurysm sac. Type 3 basically is where the pieces that I've talked about come apart. Again, these are not that common, but this is also a high pressure endoleak when it happens. Sometimes you can reconnect them by doing this basically endoluminally or endovascularly. Sometimes you got to operate in these patients. Type 2 endoleak, again, every manufacturer draws a aneurysm for a stent graft as a closed sac. Now, as a surgeon, first thing you do when you open an aneurysm and you split open an aneurysm, you scoop out all the blood clot that's in there. There are these little geysers that are coming out of the back wall. Those are the lumbar arteries. The lowly lumbar arteries are the Achilles heel of aortic stent grafting. And the first thing you do when you do an open aneurysm, you put a whole bunch of stitches in, you just sew them off, then you sew a Dacron graft in there. So normally blood comes down through the aorta, out through the lumbar arteries, or out through the inferior mesenteric artery if it's patent. When you put a stent graft in it, blood flow reverses. And now the inferior mesenteric artery and the lumbar arteries, instead of being outflow vessels, are inflow vessels. So when you get a CAT scan or you do the ultrasound, you see flow in 20 to 30% of patients in that aneurysm sac. Now, most of the time, these are sufficiently small or trivial that they don't cause pressure inside the aneurysm sac, but they do drive imaging. Maybe good news for this audience. We've got to bring them back again because they've got to be followed. And what we're starting to see is even the ones that had type 2 endoleaks for the first 4 or 5 years with no aneurysm sac growth, later on basically start seeing aneurysm sac growth with no evidence that they've got any of these other problems. So the imaging of type 2 endoleaks basically is extraordinarily important. And this is a lot of the things that you're going to see basically in these labs. You really, and how you do that is very important. We need a venous phase, you need an arterial phase, and you need delayed imaging. And this is an example of dye in that aneurysm site. Here's the stent graft. Aneurysm don't look all that big, but you shouldn't see that dye occurring in there. We need thin cuts, and these need to be down to the 0.25 millimeter range so that we can actually see where these lumbar arteries, particularly if we're planning to intervene on these patients. We don't care what is going on above and below the stent graft. Now, this is the example of tailoring the imaging for the question that we're asking. We don't really care. If the plan is that we're going to try and do an intervention for this, we need you to invest your time, radiation, and dye right in the area we're particularly interested in. And we should be able to spot where those lumbar arteries are, inferior mesenteric arteries. And what we use this for, basically, is to try and plan what that intervention is going to be. And there's a whole slew of different ways we can actually try and treat this. Whenever you see a slew of different ways of treating something, none of them basically are very effective. This is a little bit like a little Dutch boy. Put your finger in the dike and it springs a leak over here. And so this is a growth industry in our business, and increasingly what we've been doing is having intervened with every kind of intervention you can imagine. We're basically operating on these opening the aneurysm sac, leaving the stent graft in place, and oversewing all these vessels really from the inside. MRI has not been widely used, or MRA, but it probably may be the most sensitive in picking up these low flow states basically inside the aneurysm sac. So I think I'm going to stop there and let us basically take a break. There's a lot more, and maybe I'll catch up on some of the additional things I've got during the question and answer session a little bit later. This is the main part basically of what you really want to know. Thank you.